Finishing up the spinal cord, let's talk about dermatomes. Great example here of a word if you've never seen it before, but you know some root words. It's easy to figure out. Derm, skin. Tome, slice, like a CT scan. That's computerized tomography. Tome, slice. So dermatomes literally skin slices. So look at that diagram on the right. See, the skin is sliced up. Look at those numbers. What do you suppose those numbers mean? C2, C4, C5, C6, C7, C8, T1 down through T12. Yeah, those are spinal nerves. So what's going on here? Dermatomes provide sensory input to the CNS via the dorsal roots of spinal nerves or via the trigeminal nerve. We'll talk about that's cranial nerve number 5. We'll talk about that in the 4th section of the class. But what's going on here is that you can map the human body according to which nerves carrying the sensory information to the brain. So look there in the diagram. See where it says C4? So that region is that sensory information from that region is carried by cranial or cervical nerve, number 4. All right. Now notice this could be used to assess spinal nerve damage. Now somebody in some sort of an accident, some sort of trauma occurs, and you test them. You touch that area and say, can you feel this? Can you feel this? Like the old Verizon friends, can you hear me now? Can you hear me now? Feel this? Can you feel this? So notice, let's say you're touching right by their neck, right where C3 is, and they're saying, yeah, they can feel that. Then you get down a little further where C4 is, and they say, no, they can't feel that. And then you get down to where C5 is, and they say, yeah, they can feel that again. Well, look. You just figured out that they had damage to cervical nerve number 4. So dermatomes are an incredibly powerful diagnostic tool. They allow you to assess without, don't need an X-ray or an MRI or a CT or anything. Just a simple, physical exam, and you can identify nerve damage. I mean, it's not always that simple. You still may need imaging and other things like that, but I'm saying at least the starting point is you can figure out what's going on simply from a superficial examination. This can also explain what's called referred pain. Referred pain is very interesting in the sense that sometimes you don't feel pain exactly where it really is. This happens especially with pain from things deep down inside, not skin, all right, but things underneath the skin. What can happen here? So, for example, look at T1. Notice how T1 is up there, thoracic nerve number 1, is up there in the chest, but notice it goes all the way down the medial aspect of the arm. Well, during a heart attack, what happens is your heart, is dying. Basically, it's not got oxygen, so it's in a lot of pain. Your heart is sending pain signals, and notice your heart is going to be where like T1, T2, T3, T4, somewhere in there, T5. So it's going to be sending pain signals to the brain along those spinal nerves, thoracic 1 through thoracic 5. Well, the brain often can easily sort out signals that are coming from the skin, pain signals from the skin itself, but pain signals from organs underneath the skin, sometimes the brain has trouble sorting out exactly where the pain is from. And so you will then experience pain anywhere within the dermatome. So you may have heard, when people are having a heart attack, what can the symptoms be? You'll feel pain in your chest, but also down your left arm. Remember, the heart is about 2/3 on the left and about 1/3 on the right. So what will happen is in a heart attack, the pain signals will be getting sent along the first 3, 4, 5 thoracic nerves, but your brain has a tough time figuring out exactly where the problem is, and so it will make you will experience pain. As we'll see when we talk about the brain, pain really is in the brain. It's not really on your body. Pain is in the brain. So when your brain gets signals along thoracic nerve number 1, your brain thinks, uh-oh, maybe something's going on with the medial aspect of the left arm. And so you will experience pain there. That's called referred pain. Same thing can happen like in appendicitis, or if you got gallstones or kidney stones. you'll often feel pain in a much broader region than where it actually is. The appendix is on the kind of in the right inguinal region, but you may feel pain all the way up into the stomach. All right, so that L1 goes across the middle. You may not feel it just on the right side. You may feel it across the middle as well. So that's referred pain. It can also be used to determine how to administer anesthesia to portions of the body. So for something called phantom pain, you may have heard of phantom pain before as well. This is a common occurrence with people who get amputations. Let's say, whatever happens, some kind of trauma, you have to have your arm amputated at the elbow, right? Well, notice, cranial or cervical nerves C6, C7, C8, thoracic number 1, go all the way down your forearm. And when they amputate your forearm, the nerve endings are still there, and they still run all the way back to the brain. It's just they don't go all the way down to the bottom. Well, what can happen is, and this is a common occurrence, people with amputations, they wake up in the middle of the night, and their right arm has been amputated at the elbow, but they have terrible, intense pain in their right hand. And you're going wait, what? They don't have a right hand. Well, no, they don't have a right hand, but the right hand was innervated by C6, C7, C8, and so signals are still traveling along those nerves, those cervical nerves, all the way back to the brain, and the brain can get confused and think that the pain is coming from the hand. So called phantom pain. Sensations can be like you see in that middle picture: cramping, shooting, stabbing, burning. This is actually a terrible problem. And it's not imaginary pain. This is real pain. People are experiencing real pain, and it can be very intense. And even though that limb is not there, the pain is still real. There are a variety of strategies. One thing they can do is if it comes down to it, they can actually go over towards the spinal cord and snip those nerves. But of course, then you would also lose sensation every place else those nerves go. So that's not really an optimal solution. Another thing that they've tried is something called mirror therapy, where you have the person who's experiencing the phantom pain look into a mirror, and they can see that they don't have a right hand, and that helps the brain then realize that there can't really be any pain in the right hand because the right hand isn't there. But phantom pain is a real phenomenon. This is not imaginary. This is a real phenomenon. The pain can be quite severe. But dermatomes help explain all of that. Here's a slide talking about referred pain, so you can read that over on your own. But again, notice how kidney stones, you can feel the pain going all the way down where the ureters are. All right, so the appendix can cause pain all the way across towards the center of the abdominal region. So referred pain, very common. All right. Let's talk about reflex arcs. So you've all seen the thing where you go in and the doctor, you sit on the table and you dangle your leg, and the doctor, hits below your knee and your leg jerks. That's a reflex, all right? You have lots of different kinds of reflex, but let's look at reflex arcs. These are great examples of homeostatic feedback loops. So the pathway followed by a nerve impulse that produces a reflex is called a reflex arc. So you see it right there in the diagram, the 1, 2, 3, 4, 5. So look what happens. Attack. Some horrible person has just stuck a tack into your arm. I would say don't hang out with this person anymore. But they stick a tack into your arm. So remember, that's going to be a sensory nerve. That's an afferent, ascending. The nerve is not ascending, but it's an afferent nerve. So look, it's coming in. There's the cell body. You can see it there in the dorsal root ganglion. And the nerve is coming in then through the dorsal horn. It's synapsing there with an interneuron. And then the interneuron, notice, is going down into the ventral horn where the cell bodies of motor neurons are located. And then a motor neuron sends a signal out along the ventral root. The ventral roots are motor. Remember the race car, vroom. So it goes out to a muscle that will cause you to smack that person in the mouth. say, damn, stick a tack in my arm, I'll teach you. More like what it is, though, is it would just be an involuntary thing, where, you know, as tack sticks in your arm, suddenly your arm flails up near you, go, ow, that hurts, all right? That's a reflex arc. Starts with a sensory signal, then there's the interneuron, and then you end with a motor signal, all right? That's the response to the sensory stimulus, okay? So a sensory receptor responds to a stimulus, sensory neuron conveys impulse to the spinal cord. Integration takes place in the spinal cord, conveying the impulse to a motor nerve through what's called a monosynaptic or polysynaptic reflex arc. Monosynaptic, one synapse, polysynaptic, multiple synapses, all right? Motor neuron then conveys the impulse to the part of the body that will respond, and an effector organ, a muscle or gland, responds to that motor impulse, okay? So somatic reflexes involve skeletal muscles, autonomic reflexes involve smooth muscle and gland. We haven't really talked about the nervous system yet, but we just keep trying to preview this stuff, all right? So somatic is going to refer to skeletal muscles and to skin stuff. Autonomic refers to the involuntary things like digestion and breathing and heart rate and so on, all right? So again, reflex arcs are great examples of homeostasis, all right? You've got a feedback mechanism here. The sensory signal comes in, you know, you have the control center, and then there's an effector that brings about some kind of a change, you know? I mean, imagine if that tack were, you know, let's say something that was really hot, like a burning match, falls on your arm. You know, the sensory signal is going to come in, and you're going to then end up moving your arm to get away from that burning match, all right? So this is a negative feedback loop. Here you see again, the stimulus comes in, you got the skin receptor, nerve goes out through, there's the cell body and dorsal root ganglion, synapses with an interneuron, sends a motor impulse out to a skeletal muscle, and that's the response. So let's look at the stretch reflex. That's our first reflex arc. Stretch reflex occurs in response to the stretching of a muscle. And the classic one, again, is the little knee tap here, all right? So we have the patellar ligament down there, all right? And the little hammer taps on that. And what that does is that's ultimately going to pull on the muscle. It's going to stretch the muscle. So stretch reflex is monosynaptic and ipsilateral. So monosynaptic means one synapse. Now this is a little bit confusing because there's actually more than one synapse. But once we look at other reflexes that are polysynaptic, you'll see that they have a lot more. Monosynaptic has one main synapse. And ipsilateral, ipsi, this is a good prefix to get to know. Ipsi means same, lateral side, so ipsilateral, same side. In other words, when the doctor taps your right knee, you know, the right side, it's not your left leg that kicks. When you tap the right side kicks, all right? So that's ipsilateral, same side. So stretching stimulates what's called the muscle spindle organ. So deep in the muscle, there's an organ that's designed to detect stretch, all right? So impulse sent along a somatic sensory neuron to the dorsal horn, all right? And what's going on here, this is basically your body's response to something's happening that you didn't want to happen, and so you respond by basically saying, hey, let's put things back to normal. So when the hammer taps there on the ligament, it causes the muscle to stretch, and your spinal cord says, hey, I didn't cause this to stretch. That's weird. I don't want that happening. And so, as a result, the impulse is sent back to the muscle, telling the muscle to contract. So notice that's negative feedback. We started with the muscle stretching. The feedback loop causes the muscle to contract and restore things to normal again. So spinal cord, the sensory neuron synapses with the motor neuron on the ventral horn. An excitatory motor impulse conveyed along the motor neuron to the muscle, which contracts, and that counteracts the stretch. Sensory neuron also synapses with another motor neuron, because you want an inhibitory motor impulse to be sent to the antagonistic muscle. So remember, in this case, the little hammer is going to stretch the tendon going to your rectus femoris. And so the rectus femoris is going to stretch. Well, in order for that to happen efficiently, you don't want your hamstrings to contract. I mean, the rectus femoris is going to contract. You don't want your hamstrings trying to contract at the same time, because then your leg wouldn't move. You would have the spastic paralysis type of thing going on. So at the same time that you want rectus femoris to contract, you want to make sure that the hamstrings, things like biceps femoris and semitendinosus and so on, you don't want those to contract. You want those to remain loose so that rectus femoris can contract. So that's why, that's the other synapse here. So monosynaptic, because the main synapse is with, in this case, the rectus femoris, causing it to contract to counteract the stretch. But you also have to make sure that it's able to do its job. And for that to happen, you want to send an inhibitory impulse to the antagonistic muscles, in this case your hamstrings, okay? So that's the stretch reflex. That's monosynaptic and ipsilateral, because there's only one main response here, one main synapse causing the muscle to contract. The other synapse was just to make the antagonistic muscle stay relaxed. And here you see what we're talking about. These are the muscle spindle organs, all right? They respond to a stretch in the muscle, and that signal then is sent to the spinal cord. So muscle spindle organ notifies the spinal cord if it's being stretched. That's how your spinal cord knows to respond. So let's look at then the other example, the cross extensor reflex. So in this case, notice I love the diagram here. So in this case, you step on a tack with your right leg, all right? So in that case, you want to pull your right leg away from the tack. You don't want the tack to be, punching into your foot. But if you're going to lift your right foot off the ground, it's kind of important that your left foot is planted on the ground. Otherwise, you're going to fall on your ass, all right? Or probably your face is where it's going to be. So what you want in this case is you want the one side to pull away, but you want the other side to make sure to plant itself so that you'll not fall down. So cross extensor reflex is polysynaptic and contralateral. Here you really do need motor impulses going to both sides of the body. Both sides is polysynaptic, contralateral both sides, and polysynaptic because you've got two different muscles that you have to control. So cross extensor is an intersegmental reflex. It goes up and down the spinal cord here, not all at the same area. So painful stimulus to the right foot sends impulse along a sensory neuron, just like before. That sensory neuron synapses with several neurons on the same side and on the opposite side, hence contralateral, crossed extensor. So the motor neurons on the same side flex the limb, all right? So notice you're going to flex your right lower leg to pull it away from the painful stimulus. But then on the left side, you want the left side to extend to ensure that your foot is planted on the floor, all right? So that's why it's the crossed extensor, all right? The side that's affected flexes, but the opposite side needs to extend. So inhibitory motor neurons also cause inhibition of the necessary antagonistic muscles. So once again, we've got these extra synapses that we're not really talking about, except for the fact that you have to make sure that the antagonistic muscles stay relaxed. So those are the two reflexes that I want you to know, the stretch reflex and the cross extensor reflex. Good example, again, of a monosynaptic ipsilateral reflex versus a polysynaptic contralateral reflex. And there you see involuntary versus voluntary motion. There is involuntary motion, all right? This is not something you consciously will. This is a reflex arc in the spinal cord, whereas in this case, you are consciously kicking that guy right in the face. And that's awesome. My son is a mixed martial arts fighter. He does things like that. And yeah, he's kicked people in the face before. It's awesome to watch.